are interested, or those of us who are still yet to make up their minds about whether to go abroad for the residency program or to do it, or those that made up their mind to do it in the country. Today we'll be having and we'll be taking a look and seeing what it's like from the horse's mouth. That is those that are currently doing emergency medicine residency here in Nigeria. So thank you once again for joining in. Thank you for being members of this amazing organization. Before we begin, I'd like to appreciate all of you and also say a happy new year to you all. And we look forward to a lot of amazing things in emergency medicine interest group of Nigeria, especially this year. Would require your commitment, your participation, and all our activities as we move forward. So thank you very much. Let me confirm if our speakers are here yet. Okay, so our speakers are in the house, and at this moment in time, I'll be reading the citation for the two speakers in no particular order. I'll be starting with, I'm so sorry, Ma, if I don't get the pronunciation properly. Dr. Towenna and is a second-year emergency medicine resident at Cedar Crest Hospital, Abuja. She's passionate about acute care medicine and providing life-saving emergency intervention. Besides volunteering and medical practice, Dr. Aguka is a baker and prides herself as a self-taught cake artist. That's very beautiful. Thank you very much, Dr. Towenna Aguka. And then, are you in the house?
Yes, I am. I'm here. Thank you for
okay.
the intro.
Okay. So you'll be having the floor. Then secondly, we'll be welcoming Dr. Simioluwa Agu. She's also an emergency medicine resident at University College Hospital, Ibadan. She's passionate about delivering high quality emergency medical care to patients that require them. She has a special interest in critical care, trauma, and mental health emergencies. Outside of high pressure, fast paced, and unpredictable emergency room, she loves to sing, listen to music, and spend time with family. Please, with a round of applause, help me welcome both Dr. Towenna and Dr. Simioluwa to the stage. Dr. Simi.
Hello.
I'm welcoming you to the stage. Yeah, we can hear you, ma. There are lots of virtual claps for you.
Oh, okay. Thank you so much. Okay.
All right. So, would you want to briefly say something before we go on to the fireside chats properly?
No, just lead the way. Let me know when you need me to come in. I'm happy to be here, actually, to share a few thoughts, because when they told me I was going to speak, I laughed because we're still learning on the job and we're equally surprised at a lot of things. But yeah, so just let me know whenever you need me to comment.
No, yeah. It's not going. It's a fireside chat, so there will be a lot of questions and you'll be answering. So you're the speaker on the
So I'll just say a few things then before that.
Okay, all right then. Okay, the floor is yours, ma. Hello, Dr. Towenna.
Okay, I can hear you. You broke a lot, but I can hear you now. So I said I would like to say a few things before questions coming, if that's okay.
Okay. So just a moment. Let me quickly send you a message. before then, please, I just want to confirm. So sorry, Ma. Before that, I want to confirm, is Dr. Simi here? The second speaker is share around, Dr. Simi. Please, Ma, if you're around, kindly introduce yourself. Okay, I think she's not yet here. Okay, so before then, so Dr. Towenna, you can kindly go on. And I also sent you a message on Zoom. Hello, Dr. Towenna. Hello?
Hello.
Yes, can you hear me?
Okay, yes. Okay, so just a few thoughts on
Okay, we're so sorry for that interruption. It seemed she was interrupted either by the network or something. We've lost her connection over there. So let's kindly hold on while she joins back.
Hello.
All right, thank you very much. We lost you there just for a second. Okay,
yeah,
so go
I
on.
had to go to a different room. Okay, so just a few thoughts on EM residency.
Okay.
I think not as okay, well, I'm biased, but then this is I would say one of the best fields because of the obvious pros like the diversity in cases and scenarios. There's no I don't think there's any practice where you get to enjoy or forget the subspecialty training, the everyday life. You get to do a lot with a lot of patients from different specialties. So you don't need to foresee it to the end, like internal medicine. All you do is you do your acute care and you move to the next department. So aside the diversity, you also have, because of the way the structure, you sort of have coverage. You just keep your patient alive in quotes. And that's not a just, that's a big deal. So you keep your patient alive and send to the necessary unit to continue care. So if for any reason you missed something, but your patient stays alive, you haven't done anything wrong because the next person who is likely a senior takes it up from there and care continues. And in general, I mean, there's a lot of them. Maybe we'll speak more during the question and answer because that will be more tailored. But then it gives you the opportunity to enjoy teamwork. It's like at any point in time, you're not alone, not because of your seniors, because of your co-workers, and when I say co-workers, I don't mean your direct colleagues like your fellow doctors. I mean the nurses, the health cares. Here at Cedar Crest, that's kind of how we are trained to run the place. So your nurse knows why you're doing this and is doing the other thing for you and just gives you a feedback. So it's a specialty that allows everyone around you to grow. Unlike the usual trend in Nigeria where the doctor is the king, every other person is around. Yes, certainly you're supposedly the king, but in emergency medicine, like all of you rub minds together and then you hit a diagnosis and you take it up from there. And of course, the blend with the surgical and medical. I mean, I'll speak for myself. For for most of my medical school years, I can't say I knew exactly what. I mean, it kept fluctuating. At first, I'm like, oh, I'm doing pediatrics. Next, I'm like, surgery is it. Then another time you do surgery posting and you're like, no, I don't want to do this. So there was that confusion of, do I want to be a physician? Do I want to be a surgeon? The beauty of emergency medicine is the blend. So you can come to work today and everything you're doing is medication, talk therapy, and the person goes. You can come another day, is entirely psychiatry. You can come a different day. It's true. You can come a different day and you just keep going from chest tube, femoral, this, that. So it's a blend, orthopedic, traction, this, that, that. Or even the part, I mean, some of us don't like to hear, emergency deliveries. So it gives you a blend of both worlds, especially if you're an adrenaline junkie like myself. You don't like boring practice. You don't like to come to work and predict your day. Emergency medicine is what you need, and it keeps you alert. Oh, you've come to work at 8, you're leaving at 5. You don't know when it's 5 p.m. because you're always busy till 5 p.m. The call room exists, but you don't even know it does, to be honest. You forget. I mean, sometimes it's not a good thing to forget your snack, but you learn to eat on the job. You have a chocolate bar or whatever, you move on. So it's a lot of that, and of course, then the cons anyway. So, please don't mind me. I could keep going on and on, except you tell me we move over to the question and answer session.
I think you are muted.
No, it's not. I said to tell me if I needed to continue.
No, I mean Dr. Lama.
Okay.
Hello. Can you hear me?
Yes.
Okay. Thank you very much. Sorry, I had a bit of a connectivity issue there. So thank you very, very much for sharing all of this. Honestly, like they said, I hope I'm not hope you are not speaking and I interrupted the flow. Hope you are done.
No, I
Okay,
was
all right.
done. Yeah.
Okay. Thank you very much. So just to just to say something on something you said, I think there is a session we once had and they told us that the best first 15 minutes of every specialty is basically emergency medicine. So I really love the fact that you buttressed on that fact, because truly a lot of us do not really find a place in one specialty and then don't want to keep doing things over and over again. And like you said, and I remember during our boot camp in Ibadan, I think they buttress on the fact that emergency medicine has to do with a lot of teamwork. So thank you very much for that. Dr. Simi is in the house. Thank you very much, Ma, for joining in. So we'll be starting the question, the fireside chat proper right now. And coincidentally, you've even answered the first question, which we wanted to ask you, which was why emergency medicine. But you've actually, Dr. Towenna has shed some light on that. So, Dr. Simi, just briefly, in a minute, if you could just shed light on why you chose emergency medicine primarily.
Hi everyone, good evening. Sorry, I'm just joining. I had issues with my network earlier. So why emergency medicine? So I'll say we chose each other. I chose emergency medicine and it chose me also. So I had started my residency earlier in family medicine, but I moved to my current center. And then I started as a medical officer in UCH. And when I started with emergency department. In fact, when I got there, someone was like, why do you want to stay in emergency? Can't you ask that you should be moved to somewhere else? I was like, I like it. And then when I got there, I saw the way things were done. Our consultants were already back in Nigeria then, Dr. Jifini and Dr. Akeola. And then seeing how they did things, seeing that the emergency room is it's more than just sorting people, made me develop curiosity and interest in emergency medicine. And the fact that you get the privilege of meeting people on the worst days of their lives, and you're the difference between whether they're going to die or not. Of course, you're not God, but the fact that there's something you can do to reduce mortality and morbidity at your end, to relieve stress, to relieve pains, critical stuff. Yeah, that's why I chose emergency medicine. And then the thrill too.
Oh, thank. Okay, there's something common about emergency medicine enthusiasts and everyone practicing this is the adrenaline rush everyone seems to have. So thank you very much, Ma, for joining. Like you said, we get to meet people on the worst day of their lives. Very true. Sir, the next question, please, if you could shed light on, because we're starting from the beginning, so we're moving now. So if you could shed light on emergency medicine primaries, both colleges, the national and the West African, how the exam preparations were like, and then what materials you'd recommend, just on passing EM primaries and how best to prepare and all of that. So we'll start with you again, Dr. Simi. Kindly shed light on that.
Okay, so I wrote my exam. The first exam was written in September 2021. I was part of the part of the group that wrote the exam. Will I say I haven't worked in emergency room health? I'm so sorry. My daughters are the ones doing that. Sorry. I'm not sure. It's basically biochemistry, your preclinical stuff. So I didn't write books for it. I'm not so sure. The people that wrote the last exam said that, okay, so the people that wrote for my center, they all passed, but then they were saying that they didn't repeat past questions. And then my HOD was like, we're expecting that they will repeat past questions. So maybe a little bit of past questions here and there. The essence of past questions is not to cram the answers, it's to find out, what's their pattern of asking questions. And do I really understand this question they are asking? Or I just want to see, the next time I'm saying this question, I want to see it verbatim, reading around the questions. And I think one big thing that also helped me was having a study group. All of us were studying together at some point. And I also had, out of everybody, I also had someone that I was studying with personally too. Would get MCQs. We can just browse online, and of course, because there was nothing preceding our own exam, practice and read around those questions we're practicing around, read around topics. There are topics, a list of topics that you can read around. And I know I know Dr. Adedeji and some other people, there was a Telegram page, I think as you finish exams, you're supposed to do a recall, and then they remove the people that have done the exams, and then a new set of people join. I think the Telegram page is also quite helpful too. And I think there was a WhatsApp page that was started to help with the studying. So I think what I'm trying to say is read around your past questions, don't just read them verbatim, and have a study group. And whatever works for you, really, those things might not necessarily work for you, but whatever you've seen work for you, do it.
Okay, all right. Thank you very much. I can see questions in the chat. Actually, we have most of your questions already captured in our list of questions that we're going to ask, taking them step by step, but we'll make sure that the speakers actually attend to all your questions. We're taking note of it. Dr. Towenna, would you like to add something briefly before we move on to the next question about preparing for emergency medicine primaries?
Oh, thank you, first of all.
And also, I would like to add, as you're taking it, also, if you could shed light on if there are any financial implications of also preparing for the primaries as well. So also shed light on that, because we have a lot of people that are at different phases of their career, that some of them are preparing to write this exam, some of them want to start planning from now on how to prepare. So lest we forget the financial implications. Where are the centers for those that may be coming, so that the budget, accommodation and feeding and what have you? So we want it to be as practical as possible. Thank you.
Do you still want me to go on that?
Okay, let Dr. Towenna speak. Then if there's anything she left out, then yes. Thank you.
Oh, okay. I think that Dr. Simi can actually speak on that, because I do not have an idea of other centers per se. I just know, so I wrote in Abuja, so I just know about that. Financial implication, I think it's the same as any other primaries. Then some things she said, anyone that's written an exam will tell you it's more of pre-clinicals, because obviously it's a place where the structure has not really been set entirely. So questions and all that is still majorly, in fact, I laughed at some of the questions, because I'm like, emergency medicine, I have not really seen here. Like, so a few, like 5 or how many. The rest were more about chemistry, microhistology. So, but about cost and all of that, I can't say much. So she may know better.
Okay, thank you very much. So, Dr. Simi, back to you, ma.
Okay. So when we wrote, she said, I think there's still a lot of evolution in emergency medicine in Nigeria, including even the primaries exam. We wrote in, I think 7 of us from Ibadan went for the exam in Ife. 5 of us went a day before, and then we had to lodge in hotels. So you have to think of that also. I don't think there's a center in Ife again. I think it's now Lagos and Abuja. I think the Ife center has been scrapped. So you have to think of transportation costs. You have to think of accommodation if you're not going that same day. Some of us came in that same day. I feel it's a little risky, but of course it's Ife to Ibadan, so they could risk that. But then if it's Ife Ibadan to Lagos, for example, you want to be extra careful to make sure that you leave as early as possible if you want to leave that same day. That cuts the cost of accommodation on your part. But of course, definitely transportation, even if it's in your state, you still need to move yourself there. The exam was 70,000 naira then. I'm not sure if it's still 70, or I'm not sure where I saw 120. I don't know if it's something else I'm thinking of, but I know it's between it was 70 then. I'm not, but of course you'd have an idea of what it is. They will bring it out when the forms are out. So that's it. So exam, accommodation, transportation.
Okay. All right. Okay, I think someone posted that the cost for the exam is now 100,000. Okay, and someone is saying there is a center there is a center in Enugu for those in the south that they wrote in Enugu last year. But I think I think they always, before the exams, whatever college it is, usually provides information on the available centers and the cost. So make sure to check that out. So we'll be moving to the next question. Please, if you do have questions, write them all out in the chat box. I'm taking notes of everything, and they'll present it to our speakers. So, can you share your journey on how you got your emergency medicine residency placement? At times after writing the primaries, I'm not sure about emergency medicine, but some people have shared the challenges in terms of getting placements in the right places and all of that. So can you shed light on how it is to get emergency medicine placements in Nigeria, and what you would advise young doctors and all of that to consider when choosing a place to do residency? Because that's somewhere to spend almost 6 years of your life. So I feel it's a very important decision where to apply for placement and how to apply for this placement. So Dr. Simi, we'll start with you again.
Sorry, who is going first?
I said Dr. Simi, we'll start with you again.
Oh, okay, thank you. So I told you I was already working in UCH already. I was working as a medical officer. So the first set of us that started were converted from medical officers. Sorry. So the first set of us that started were medical officers, but I know to get placement in UCH, of course, UCH will call for application, or there's slots for residency training, and you also have to be eligible. You obviously have your medical and dental Council of Nigeria certificates license. You've passed your primaries exam, or there's also the possibility of actually starting and writing your primaries later in the course of the program, but I'm not sure for how long that is on the table. You know, when things are fresh, you can afford to take in people before they write their primaries exam. And okay, then there's also the part of, oh, I want to study in this center. Currently, there are 7 centers in Nigeria offering emergency medicine residency training program. We have UCH, there's Cedar Crest, there's excuse me, there's Lagos State University, University of Benin Teaching Hospital, University Teaching Hospital, Bauchi, and then Ahmadu Bello University, Zaria, and UNTH Enugu. So if you're going somewhere, I would assume that you probably have someone in-house. Maybe how connect me to your HOD, how do you guys do things? Can I get a letter of recommendation from someone in your center or someone in the department that I'm going to? So those are things that can boost your chances. If I remember, there was a particular lady that wanted to do residency, of course, before she traveled out of the country, because the head of department then had known her and all of that. When they were calling for residency, in fact, HOD was asked for a number. I was like, this lady, she's still. I'm so sorry.
No problem.
Sorry. Is this lady still interested? He kept on looking for her, and then we found out that, oh, she had gone abroad, and okay, of course, that slot opened up for someone else. So getting the people in the center you're interested in to know that, oh, I'm interested in coming along. If something shows up, I'm your girl, I'm your guy, please call me. I think that helps too.
Okay, all right. Thank you very much. Dr. Towenna.
Okay, I would say that just like her, I think I was opportune to have been in Cedar Crest when we got accreditation as well. So
Okay.
I was working as an MO as well. And Cedar Crest had been pursuing the accreditation actually, because we do have a consultant in emergency medicine from the UK. So who heads our program over here. So he had been trying, I think, over a year, and then suddenly that December we got the accreditation. So we started January 2022, or mixing up the dates, but yeah, it was the following year. And so they just asked, so I was here, but also always in the ED. So when he just came to us and like, all of you in the ED, who wants to actually do this thing? Not that you're in a place with high pressure, who has interest? And a few of us showed interest, and that's how we got into the program. Then, like what she said, whilst in the program, then attempted our exams. So, but subsequently, people joining have had to have their primaries as a requirement to join the program. I think that's the major thing. But yes, even those that joined us, they didn't just come from anywhere. They knew one of us, you know, that sort of thing where you're communicating with someone and the person tells you, oh, this is who you should meet, who, just like what she said. It's not like you cannot come without knowing, but it just makes it a lot easier. Not that you necessarily need to do anything different. It's just that you come into a place, you know exactly, because still is a new program, new-ish program, and you can ask the next consultant and it's like, I don't know, that sort of thing. But if you know exactly, for us, our consultant comes in, he has this 2 weeks in, 2 weeks out arrangement with Cedar Crest. So it's always best to know someone in the place so that they can tell you, oh, this man is around at this time to this time, so that you can follow.
Okay, all right. Thank you very, very much. So to the whole house, I hope we're learning. I hope this is piquing our interest in emergency medicine in Nigeria. So thank you very much, Dr. Towenna, and thank you very much, Dr. Simi. We'll now move on to the next line of question. So, if you can, and this is where I actually want your different experiences. I wish we had more, all the 7 centers here, so that people get to see it through everyone's eyes. If you can kindly run us through what a typical day in the life of an emergency medicine resident in your center looks like. What is the work rate like? The calls, how are is it, do you run calls, do you run shift? What are the work hours, and what exactly is, to what extent is your job description? Where does it stop? Where does it start? So I'll start with you, Dr. Towenna. If you can run us through what your day looks like, what's your schedule like in a week? How many calls do you run? How many shifts do you take? How long do you work? I want to know all of this. Start with Dr. Towenna.
Okay. Sorry, I had to put my video so it's easier to put a face. So a typical day, so we did something for ourselves. In Cedar Crest, generally, we have a work schedule, a 2-week work schedule. You get to work 2 weeks straight, you get off on the 3rd week. That's what every doctor, every medical officer does. So 1 week day shift, the next week night shift, the 3rd week off. So, but when we started the program, it didn't seem like it worked because it was super hectic, having that kind of shift with teachings and trainings. So on our own, we changed it. So it's just, I think every center will have what they're doing. I don't think anything is generalized. So we work 4 days, 3 nights, and get 4 days off. In the middle of your off, you can have a training you have to come for. I mean, it's a necessity, it's obligated. It doesn't matter if you're on or off. So the following week after that, you then do 3 days, 4 nights, 3 days off. So the number of day shifts you do determine your off days. And for us, so at some point we wanted to change it and have some days in and out, you get to rest, but it didn't seem to work. I don't know, anybody in the ED is used to stress. It's a bad thing to say, but yes. So we saw that we prefer to do all of it and then rest. And that's how we've been taking on since then. So a typical day in the ED, it varies. No days are like, to be honest. And here is, so when I started, we like to pride ourselves as a level 2 trauma center. Sometimes you find my MD saying level 1. But anyway, in a town like Abuja, there's, so the common thing is road traffic accidents because of the wideness of the roads. So a day in the ED, you must have at least 1 RT, at least 1. So you find yourself having more of trauma than medicine cases. So, and then there are peak periods for that. So festive periods and all of that. In fact, that's the major thing. But I also think that Cedar Crest being formerly totally orthopedic, some people still think it's primarily all that we do. So it's just the point of trauma here. So, but things have sort of evolved since we started, maybe because of, the society, T-pain experience or whatever. We now, a typical day, you may go a whole day, you haven't seen trauma or you haven't seen acute trauma. It's just someone waltzing into the ED and telling you, oh, it was 72 hours ago, this accident happened. I'm just here to make sure everything is fine. But the usual day we have is, so we have a drill. You get an RTA, you make the call, like trauma team to resource. So the trauma team comprises of the ED doctors that head the trauma team, the anesthesiologist, the orthopedic surgeons, most times general surgeons in case it's a cardiothoracic issue, abdominal, plastics, and of course the nurses and healthcare is involved, and the porters and healthcare is involved. So once we make that call, it goes to the whole of the hospital. The speakers are around. So once they hear it, you know the way we say the first thing in emergency care is call for help. So once we call, once they hear it, the whole hospital, everyone knows who to call it for and who to come down. So it's not just consultants coming down to share knowledge and act smart. There's designated people. So we do we go through the ABC. So if there is a need for airway, the anesthesiologist knows what to start with. But this doesn't stop us from starting initial care. Because we heard it, we still tell them. It doesn't matter if this is a professor. We are the ones to say what we want, in quote, in the absence of our consultants, and everyone works with it. Then in medical cases, we just say ICU team to resource, that sort of thing, because then this is just a patient that's either unconscious, that you need high dependency, you need care for, or ICU, or you just want to stabilize and then move to the next. So that is, and this thing I'm saying is not like, it's a casual day, really. You come to work and this is what starts your day, but you come at 8, you leave at 5, it never happens, by the way. We always leave 6:30. There's always that rubbish case that comes 4:30 and you're kept. But in my experience here, in a good day that you don't have anything doing, it's a private hospital, it can be a total of 10 patients. On the day that God has remembered you, you're here, you can see up to 20 and counting, like mass traumas. Like, so this first week of January, what welcomed us was mass trauma. I think it was a 54-seater bus that collided, and it was at Kogi. So they got initial care and then drove through the night and headed straight here because they had a sponsor, a politician who said, send to here, I'll cover. So we had people sitting down. So the first thing is you triage. I should have said that actually. You triage, you give people codes, be like, okay, this is a green, this is a yellow, this is a red. In between yellow and red, you can say this is an orange. And then that determines how you see them based on priority. If it's a green, he can be there, he can wait. We have a 45 wait time, but minutes wait time, but the person can wait for more than that because you're sure the person is stable. So you do your initial. So you take quick history, you're not doing the whole system by system, you're just doing a quick history and you move to the unstable patients. So days like that, yes, it is super busy, but days like that can come again, peak periods, festive periods and all. Through the year, not as much. You can have that once in a month. So yes.
Sorry, just to confirm, you said that you people have 4 days. That's the current system if I run is like 4 days. Well, when you mean those are on day shift, those are the ones that work 8 to 5, 8 to 4.
8 to 5.
Then,
we do 8 to 5.
Okay, 8 to 5. Then the night shifts, when do they start work?
Exactly. So night shift is longer, it's 15 hours, 5 till 8.
Okay, for those who
So
when
we're a
you're
team
on
of
day shift.
six. Let me make it make sense. We're a team, currently
Um,
we're a team of 6 residents,
okay, all right,
our consultant. So the six, we are in pairs, two, two, two. In fact, we're 8, but like 2 are already on their outside posting for this year. So the rest
okay,
are 6. So 2, my colleague and I, like today we're on day shift. We finished at 5. The other
okay.
people started from 5, they'll finish 8. My colleague and I will be here 8 again tomorrow morning to continue.
Oh, okay,
So when we complete our 3
understand.
days shift, which is tomorrow evening, on Monday, we move to night. So Monday to Thursday will be night shift for my colleague and I. While those that were on night currently, they will go off from Monday to Thursday to come back Friday.
Okay,
So whilst they come
okay,
back Friday, my colleague and I will then go off. The idea is to work 1 week straight, no matter how the day and night is arranged, and then go off.
right. All right. So thank you very much.
Thank you.
Dr. Simi, let's hear how the experience is like in UCH Ibadan.
Okay, Dr. Towenna, thank you. It's so beautiful to see how similar things can be in the emergency room. So we run 2 shifts. We used to have 3 shifts in UCH, but because of all the old Jackpot syndrome, our numbers reduced. So we have 2 shifts, day and night shifts, 8 to 6, 8 a.m. to 6 p.m. and 6 p.m. to 8 a.m. the following day. And then at each point you have handovers. There are residents, like they have in Cedar Crest also, there are residents in each shift. We are 8 in all doing residency training now. And so we have at least 2 people or maximum of 3 people in a shift, because there are 3 shifts. You do 3 days of morning, 3 days of night, and 3 days off. And like Dr. Towenna also mentioned, your off day, you might not really be off day, because, okay, so for us on Tuesdays are our academic days. Sorry, I'll try to make my voice go over. Tuesday is our academic day. And also we start with, after handing over, we start with our departmental meeting at 9 a.m. It might be a resident or anybody presenting, the consultant, a medical officer, a rotating resident. After we finish that around 11 a.m., the medical officers go on to keep on working, but that's our own academic day as residents. So we usually meet around anytime from like that past 11, 12 noon-ish. So we do presentations, we work on protocols. If we're working on research, we do that. We do tests, MCQs, we can do simulations. It depends on what is needed for what is planned for that particular day. We can be on that till around 6 p.m., past 6 p.m. sometimes. So it's an off day because you're not working. You are not you are not really working in the emergency room, but it's not an off day because it's a lot of lectures, a lot of academic work. And there are times that because we are short-staffed, there might just be 2 or 3 medical officers on ground. And then if they feel overwhelmed, they bring in an RTA now. It says it up, but everybody's bringing the patients to usage. And of course, you don't say, oh, residents, keep on doing your meeting. Let the 2 medical officers attend to the 10 red patients. The old triage form thing, green, yellow, orange, or red. So of course, we're going to have to leave that meeting and attend to patients. So that's our academic day for that day. So it really varies. And there's really no typical day like that in the emergency room. So there's this thing that is used to describe the emergency room, VUCA: volatile, uncertain, complex, ambiguous. You can't tell what is walking through your door the next moment. You can, in fact, if it's quiet, please don't say it. Just look at each other and smile. Because once you say it, you just hear that loud siren from the FRCS boss. FRSC boss. They've come with 2 unknown patients that they've come to drop for you to be sorting out what to do with them. So just when you say just not good, that, oh, today is calm, not good, because really you don't know what's going on. So 3 days, 3 nights, 3 offs. Your off might not necessarily be off because you can be called at any point in time to to do something. And then teamwork, there's a lot of teamwork. Let me give an example. There might be 3 or 4 people on a shift. For example, we had a case of gunshot to the buttocks during the course of the weekend. I was the one in the resuscitation room. The patient was taken to resuscitation room, and then we started. It wasn't a one-person job. I had to call in another doctor that could leave who she was seeing at that point because of the level of priority. And then the nurses, we had even nursing students joining us. And unlike Cedar Crest, where you have a trauma team, we sort of have a trauma team, but it's not as organized as, oh, you call over the public address system and then everybody comes in. No, as emergency medicine person, as emergency medicine resident, you're the one doing the initial resuscitation. You're the one taking care of the life and limb threatening conditions. I don't want to take in charge of the airway. They need to intubate, tell the nurses to suction, all of that. You do your initial resuscitation. You have a fracture, you have a wound, you irrigate, you splint your fracture, you reduce your dislocations, you send for x-rays. Because even the orthopedics team that is in your trauma team is probably in theater, or they are seeing somebody else on the road. And then you're not going to leave that limb dangling because you're waiting for them. So you do all of that. There's need for ICU care, you start. So we have a mechanical ventilator in our emergency room also. So if there's need to place a patient on that, we do that as an interim before the patient goes to the ICU. So there's really no pattern. It might be a quiet day. It's not always quiet. It can start as quiet, and I told you we end by 6 p.m. Most of the time, I don't live in a compound. Most of the time, I get home around past 8 p.m. and then 8 a.m. the following day, you have to start your second day also. So there's no, oh, I'm going home by 6 p.m. in the emergency room. Okay, January 1, for example, I was on shift and I was thinking, oh, January 1 is the beginning of a new year, let it be calm. And then all the RTAs, people that were going for crossover nights and all of that. So there's no pattern to it. And like Dr. Towenna said also, the emergency room is not first come, first serve. So you can't say, doctor, I've been waiting here since. Sorry. But of course, you have to be conscious. You have to explain. Sorry, ma, this person I'm going to attend, that I'm leaving you for, will die if I don't go there. Do you want the person to die? No, quickly can attend to the person. No. So those are some of the things you get to experience in the emergency room. Thank you.
Thank you very much. So it's also 3 days, 3 days shift, 3 night shifts, and then 3 days off, which may not be off as well. So I guess it's although if we've noticed to my fellow participants, they did not call ward rounds. So just to be certain, I've heard this before that there is no ward rounds in emergency medicine training and all of those things. My next question actually is that you just briefly, just in a few 30 seconds to a minute, what's the rotations like? Like, are you just going to be in the ED all through, especially as a junior resident, or do you have other outside postings you have to take? Just briefly, I know there is already a curriculum that is usually provided, but if you can just shed more light on that. And then also just sprinkle in the answer to my word round question. We'll start with Dr. Simi. Hello?
I'm trying to.
Hello.
Okay, so I can hear you. Starting with the word round question. Yeah, we have word rounds, but it's not the typical long word round of saying the same thing over and over and there's no action. Maybe you can call them action rounds. It's not just word rounds because we have consultants and then they come. What is happening with this patient? What's the ABCD of this patient? what's the disposition of this patient? So we have the reception area, we have the resuscitation room, we have the short stay wards. Patients are not supposed to spend more than 24 hours in the short stay wards before they have a final disposition. Are they going home from the emergency room, or are they going to the wards, or are they going to the theater? And then we have a trauma resuscitation room also. So the essence of that ward round is to teach. They are teaching rounds, they are action rounds. So this patient has this person has this thing. What procedure should you do? What this person just suffered a cardiac arrest. What's your post-cardiac arrest management like? So that's what and then you do it, you don't just say it. So that's what the board rounds look like, action rounds more or less. So the question you asked was on
the rotations.
sorry, rotations. So there are core rotations for pre-part 1. There are core rotations, and then those are and then there are light rotations in allied specialties. Core rotations like the period you spend in the emergency room, and then we have the advanced anesthesia, advanced critical care, and advanced pediatric emergency medicine. So for that, for us, what that looks like, what how we structured our own rotation for our core MM, of course, in our emergency room, and then the advanced anesthesia, we rotated through anesthesia, went to theater, did a lot more intubation also, then went to the ICU also, rotated through ICU, that's the adult ICU, and then also rotated through the pediatric ICU. We rotated through O&G, but it was not just general O&G. We went to the gynae emergency room, and then the labor ward also. General surgery. Sorry, I'm so sorry.
No problem.
General surgery, otorhinolaryngology, ENT, foreign bodies here and there. Then psychiatry also, a good number of mental health emergencies present in the emergency room, and there's an increasing number in them. And then we rotated through radiology also. Radiology is something that we get to do a lot in the emergency room. Our point of care ultrasound. If your patient comes in, you do an e-fast, you want to know what's going on in this abdomen, what's going on in this chest, is there long sliding and all of that. Patient comes in hypotension, rapid ultrasound in shock and hypotension. So those are things, those are rotations we went through. Of course, we had been learning some of those things, and then we saw how radiologists did them, and then we came back also. And then we still have good rapport with these people. We have, in our emergency room, for example, we have CT, we have x-rays. So there are times that you liaise with the radiologist. Oh, I want to do this for my patient. Oh, what does this patient have? What's the next step to be taken? And then patient has the you can, and then you know that, oh, once you're finished done resuscitating, you can quickly take this patient to the city. So those are the rotations we go through. Aside the core being on ground, being in emergency room. Thank you.
Thank you very much. Thank you so much. Dr. Towenna, do you have something more to add just briefly so we can go to the next question?
Okay, it's majorly what she's just said. I'm glad to hear that we have similar, by the way. It's actually warming to know that we run similar operations and trainings. Yes, like she said, the program itself, like radiology, ENT, that's exactly how we've arranged it. Though it was arranged by our consultant, but it's obvious that there is a communication going on between the different training centers. So it's the same thing. You are required to stay 8 months in the ED initially. Then you start rotations. That's how we did ours. I don't know if that's what's generally required, but that was what was required of us. So you start radiology, ENT, that way ICU. It's supposed to be pediatric emergencies. However, like emergency medicine generally in Nigeria, I think is poor. Like, I think it's still getting what sometimes the things refer to as emergency is not quite, it's still continued care. It's not as acute as you would see it outside the country. If you've had the opportunity of staying outside, you could tell the differences. But so in that light, when you start the other, if it's not ICU, the other departments and specialties, there tends to be a bit of like a 40% emergency, while the other 60% is the general knowledge. But then again, it's totally good enough. It refreshes your memory and move on. Then the other thing is, so we're thought to be the first point of contact and all that. So initially when we started, I said before, you're the first person, you do everything and all that. But as we're evolving, we found out that the idea is to resuscitate, and because you've made the call and you have, in quote, help, you still realize that your help don't know, they are knowledgeable, but they don't know the emergency you want. So initially, when we call for help, you can have someone dragging the leg when the heart is not stabilized. But the person is doing that because that's their specialty. So we learn to still be, so you're behind, but you're in charge. So you call for help and then you say things like, no, this is not what I need you to be doing. This is what I need you to be doing. Then as for rounds, we do rounds in-house. What I mean by that is the other teams don't join us. We take their suggestions, but we have the final say on what works for us. So except the patient is moved from the ED to the ward, we are sort of the final say. So the moment we resuscitate and the person is stable-ish, we check with our arterial blood gas and all of that. That's the one machine we have in the ED. So if we think so, then we say, oh, okay, orthopedic team to take over, transfer to the ward. But so far as the patient is still here in the ED and we agree the patient is still unstable, we head those rounds. So even if ortho wants to take him to theater, if we say this patient is not resuscitated enough, we don't care if that's a femoral fracture. If base excess is -6, patient is not going anywhere. So it's not a fight, but it's like basically you find other teams saying, can we go? You know, that sort of thing. So it's that thing where we're like, no, we don't think this patient will do well post-surgery. This patient will end up in the IC if you do it this way and all of that. So like what she was saying, there's no word round where anybody's doing all those long jotting, very dramatic stuff. It's really action rounds. Your bedside, you know, everyone is in there from the paramedic that brought the patient, if the patient was brought in. So we're going, oh, this is how this patient came. This morning, this is what it is. The new ABG shows this. I would like to transfuse. I would like to do this, apply traction. We'll take it from there. Patient is fit for surgery. So you either get okay, or you get this patient is not resuscitated enough. Still keep for the next 24 hours. So it's really, like she said, it's really just an action round. There's no, so even sometimes the points you're giving, before you get back to the computer to document or to even put it down, if we're not doing it at once, you're not going to get all. So yeah.
Okay. Thank you very much. All right. So even though you've shed light on this, this will just be we're running out of time. So just kindly just talk briefly about work-life balance, just in a minute. Like, how is it like for a resident? Because I think a lot of people have fears and concerns about residency in Nigeria and residents not having work-life balance. Although I think I was also seeing somewhere, I was in a meeting last week, yes, and I heard the US resident also talking about the fact that they have to work prolonged hours and then there's no always a work-life balance. But just let me know how it's like, the picture is like in Nigeria. So we'll start with you, Dr. Towenna. Just briefly, since we're running out of time, what's the work-life balance for a Nigerian resident working as an emergency medicine resident? Is there, you've already talked about how the schedule is like, but is there really enough work-life balance really?
Honestly, I'll answer it in two ways, and I don't mean to demean myself to cause bias, but as a female doctor, it's a totally different conversation. As a general doctor, even without being an emergency medicine resident, it is similar to what everyone projects. However, in emergency care, like what we've been trying to say, your work hours are not, so they seem designated, but in reality, they are not, because if you're about to leave a shift and a femoral fracture comes in or head injury, you can't really walk out. You may not be on duty, but you just have this instinct to help the two on duty. They have called for help. You're really literally standing there and you just find yourself rushing right back to do one or two things before leaving. So work-life balance is there. I would say there's no balance. Work takes, I don't want to use percentages because I've not done the research, but work really takes most of your time. I find myself, I go home, the only thing I can do on a very bad day at work with patient load, only thing I can do is to eat, to sleep. And then after a night shift, there is no time to eat. I choose to sleep. It can be that bad. So, but in the long run, I would say that initially it felt mostly like that, but in the long run, you get to a point, this is bad, but you get used to the stress, and then you're even able to. So from last year, middle of last year, as a team, we agreed that we would start going out. Like you find out that your work colleagues become your life friends, as boring as that sounds, because those are the people you see all the time. You're exchanging shift with same faces, all of that. So we decided that amongst ourselves, that we'll just start doing this thing of every month. We just go to a spot from work. So we chose a spot that was next to the hospital just so that we will feel like we are going out. So that's how bad it is. And then the days that is not work taking your time, you're the next presenter at the next meeting that is soon, and you need to correlate all the clinical scenarios of PE that you've seen that most likely were not documented or missed. So it's, things that shouldn't take your time, so take your time. That's one, as a doctor. As a female doctor, that's the part where you consider marriage, kids. I'm so glad seeing Dr. Simi and her babies. I'm like, okay, it's like, okay, there is hope. It's doable, but it is crazy. Something suffers, to be candid, from what I think. It's just that I think you do better if you make sure that whatever is suffering is not permanently suffering. So I have a week that I say, this week I'm not ready. I'll have family time. When it's 5 p.m., I try, no matter how I'm passionate, I try to leave at least 5:30, knowing that, okay, my husband is at home, my family is at home, let me go. Do you understand? So some other weeks, like today, it's almost 7. I'm still in the hospital. I've been here till 7 a.m. So there are weeks like that. So I think you do better when it's a migratory change, not work takes over for this whole year. I mean, by the time you come back, there's no life. Do you understand? So if you're able to interchange it like that, you can trick the system. Yeah.
Thank you very much.
Mhm.
Dr. May, let's hear your side of the story.
Okay, thank you. I'll say it again. It's beautiful that we share similar experiences. Sorry. I once said it somewhere, and I would say it here. There's really no work-life balance. It's work-life juggling. Work-life juggling. You are just juggling things, really. There's hardly a balance at any point in time. And like Dr. Toechuku said, which I'll take note of now again. She said, whatever is suffering, make sure it's not permanently suffering. There are days and there are days. There are days you have time for your family. There are days you don't have time for your family. There are days you don't have time for yourself. You're just moving from one. Yesterday, for example, when I finished my night shift, I had some personal stuff to run. I did that till it was time to resume another night shift. So it was really crazy. So more or less, I didn't even sleep for a minute before I resumed another night shift. But of course, I did that with the hope that, oh, my off day is coming. Today has gone up already. Here it gets. So it's just a constant juggling. Whatever is suffering, don't let it suffer permanently. There was a time I had to cut my first daughter's hair. Like I scraped it because I couldn't keep up with taking care of it. She wasn't going to allow any other person touch her hair. But now she's making her hair, it's long again now. So like Dr. Towenna said, whatever is suffering, make sure it doesn't suffer permanently.
Thank you very, very much. Whatever is suffering, make sure it doesn't suffer permanently. This session has been really it's been an eye opener, and I'm really learning a lot, and I hope the participants are learning a lot as well. So on to the next question we have here for you. So what are, like, if you can kindly highlight some of the key challenges you face as an emergency medicine resident in terms of the infrastructure, in terms of toxicity at work. I know the high pressure is something that definitely comes with the ED, so all of those things. So if you can just shed light on some of the permanent challenges that you feel they are there, they're yet to be worked on, and basically how best to handle them. So we'll start with you, Dr. Simi.
Okay.
Infrastructure, toxicity from senior colleagues, and all of them.
I'll start with the toxicity part that you mentioned. So
Okay.
I'm part of the first set of people that started the program in usage. We are 4 of us currently. We're a very wonderful set of people, even the first set the people that started after us. And I think it's a leadership thing. Our HOD fosters this very beautiful environment of unity, of love. You don't have a gig and then you cut someone else out. You're thinking of the next person. So I really love that thoughtfulness. The fact that I'm sure that my colleague has my best interest at that. So the whole toxicity thing, nah, we don't have that. But some of the challenges, so although we've overcome that to a good extent, but we are still facing it in some areas. There's this casualty. So some people still have this mentality of casualty. In fact, some people write referral and say, I write casualty officer because they are used to the sorting and triaging thing. But we are moving on from that. We've had people that have come for outside postings and I've seen what we are capable of doing in emergency room, and that has increased our respect to a very good extent. And a lot of them even have HOD, our consultants, as their mentors. A trauma patient comes in now, you see a surgical resident that has rotated through emergency medicine saying, oh, they did an EFAS in the emergency room and said it's positive. Oh, so let's start working on getting this patient to theater. They won't necessarily wait for an abdominal ultrasound scan to be able to take the patient to do the damage control resuscitation they need to do for the patient. So we are also overcoming that, and I think things will only get better as time goes on. Yeah, limited resources. A lot of people come in. It's the emergency room. People are coming in on the worst days of their life. It's accidents that people did not plan for, and then people brought in by FRSA, for example. So it's not all the time that you have enough resources to cater for, do this, do that. And they don't even have relatives. So you have to do a lot of running around to get those resources. But over time, people appreciate, these people are doing this. We've even had patients or patients' relatives that came back to donate stuff. Oh, when I was here, I was treated like this. Oh, I would like to donate this. Some people specifically donate, say, oh, I'm giving this donation for trauma patients. I'm giving this. There have been times that I was in the trauma resuscitation room, and then people will come in and be like, oh, I want to donate this money to this person. This is how I also entered the emergency room. So there's still a lot of limited resources, but we have a way of going around it. We don't have enough yet, but we work with what we have. I think those are a few of the challenges.
All right. Thank you very much for sharing. Dr. Towenna.
Okay, just like she said, initially when we started, yes, you had people just like at any point they're picking your brain, but not to actually take your suggestion, but just to argue and tell you why it is not. And unfortunately, it was mostly from seniors. But down the line, like our own consultant would always teach us to stand firm. And oh, even when he's not around, he's a phone call away. So he would always say, stand firm. It's a matter of time. They will stop arguing with you and start learning from you. And just like he said, to be honest, we have consultants and go, oh yeah, now emergency people, do you agree? You know, they've said all these things, but there's that clause behind. They want to know, do you agree? So they are now picking your brain for your actual suggestion, not to argue with you. But yeah, the initial toxicity was people just berating the program. Maybe in a way, it's like, would this work? This is new. And they're not used to things being done this way, you know? So I think that is the major thing I'll say about toxicity part. Then when it comes to the other challenge, for us, it might seem opposite because private hospital or a government hospital. So the people that come to us in quote can afford care, let's say, or rather, let me put it this way: we seem to have a lot of things they need at the time for resuscitation and further treatment. But then again, there are levels to what they can afford. So you still find yourself referring at some point to another center where you know. So it's a conscience game. You know this thing is doable at this other place. You feel you have resuscitated this patient up to the point that they can actually get good enough care at this other facility. So you just wait and you send to that facility. But when it comes to if you have all you need, like the ED here is sort of equipped for the best, but we still had our challenge. And there's a day an acute stroke came, which is not so common, but this man had lived abroad most of his life, so he knew to call for help and present, or rather his family brought him in, I think 45 minutes after they noticed the symptoms, blood, speech and stuff. So he had the opportunity to receive thrombolysis, you know. So we, at that time, it's expensive and stuff. So all we did was we made the call to different centers available and we referred and we followed up and we heard that by evening this patient was walking and talking. So it was exciting to see that we were able to do that. But at the same time, if we did not act as fast and they didn't have money, is that thing where Nigeria will just like happen. So yeah, that's just some of the.
Thank you very, very much. Before we go on to, I think we've covered most of the questions that have been asked in the chat box. I think all your questions have been answered. If you still have pending questions, please write them down. So because we're almost coming to the end. We also have other residents from University College Hospital Ibadan that are joining us via the chat. Before I ask my last question, and I'm also going to use this opportunity to wait for other questions from other participants. In the meantime, the residents that are joining us from University College Hospital Ibadan, this is a time, please. Would appreciate nuggets and other things you would want to add, contributions. The floor is yours. Hello.
We have Dr. Aove, Dr. Ediaye, Dr. Adedeji.
Okay, you're very much welcome. I didn't get all the name, but you're very much welcome. Please, the floor is yours.
Yeah, hello, good evening. I'm sorry I would not be able to contribute. My name is Dr. Idiaye from University College Hospital. I just logged in, so I do not know what we're discussing. So I'm sorry I can't contribute at all.
Okay. basically it was about the emergency medicine residency experience. But it's no problem then. Thank you very much for joining in. The next person.
Hi, good evening. I also
Good evening.
joined late, so I guess the speakers must have done justice to the discussion.
Okay.
But if there's any clarification you would like to make, I'm available to speak as well.
Okay, thank you very much. And then the last speaker, the last person, I think.
Good evening, everyone. And thank you,
Good
Dr. Agbo and for the lucid presentation. Informative. My name is Dr. I'm a third-year resident in emergency medicine, University College Hospital. It's quite interesting, and it's heartwarming to listen to this presentation and see like minds. People emergency medicine as to listen to the two. I would say that emergency medicine is quite new in Nigeria, and it has own challenges. And out of those challenges, you can pick out opportunities. And then it's like Dr. Agbo rightly said, we have 7 centers running emergency medicine in Nigeria. All the residents know themselves. Maybe, but there's always a network, because it's not a large population, so we're able to discuss and relate with ourselves. And then there's this opportunity of having exchange programs within CH, and then we're hoping that a time will come when everyone will to move around. Now, Dr. Towenna mentioned that she was quite impressed that we're doing virtually the same thing in UCH and our own center. That's at Cedar Crest. It's going to be like that because there's a curriculum which can be made available to everyone here. Every resident should do. So you have the Bible in your hand. That's the curriculum of the Faculty of Emergency Medicine. And go through it, and that is what all the consultants in different institutions, training institutions are doing. And then it is also open to all the residents. You know the postings you're supposed to do, and then when your posting finishes, you know all of that. Now, thing to mention that a lot of challenges. Dr. Agbo had mentioned some of them. The name calling, casualty, and a couple of other things. It is only those that relate with emergency medicine residents and physicians that know that they really know stuff. I'd like to quickly mention one thing. Our chief resident had some encounter with some encounter with some, and then there is this comment about why do you choose to do emergency medicine that is not even stable, this, that, and then some of them try to prove that they know things. And then I think we were in surgery, and then while we were taking a case in theater, my chief resident of the senior, this is the ECG of the patient we're operating right now. Could you please operate this ECG? And then the whole theater went into silence, and then we started laughing, and then we wanted to make a point that emergency physicians are not only jack of all trades, master of none, but jack of all trades, master of many. That will comfortably treat a patient in acute state. We would read ECG like the cardiologist would do. Minimal echo for patient. We would see the acute thing and we can easily intervene, and then those in that specialty will come for definitive care. But the initial treatment, we would do them. Now, part of the challenge, aside from the doctor-doctor relationship and then the name, the fact that it's still faculty, and then even exam dates, a lot of teaching and then other issues. It is until we get past the first set of people that would finish as emergency physician trained in Nigeria, the first internally trained emergency physician, that is when we would have a lot of others would follow. So those are part of the things that we're supposed to do, because we do not have someone to tell us that you're supposed to do these things. So these are part of the challenge, and I'm sure that those coming behind would find it very easy after the first set of people have graduated. So it's really a lot of opportunities for us. Research-wise, there are a lot of never been covered in Nigeria. Thinking about this faculty and also having interest in choosing this faculty, the sky is not even the limit for us. So it's I'm glad that I've chosen emergency medicine. I'm glad I'm doing emergency medicine at the moment, and I'm happy with the kind of consultants that we in UCH are blessed with. Or allow me to happy to be a part of this discussion. Thank you so much.
Thank you very much, sir, for your contributions. Thank you. Thank you so much, really, for being a part of this conversation today. So, to our final question, although there is still a question that someone just popped up right now in the on the group. So they asked that would you advise prospective residents to join you in your centers? So, Dr. Towenna, the question goes, you would start with this: would you advise young residents come and join you in your centers?
You said, would I advise young residents to come and train where?
In your center.
Oh.
It's a question someone asked in the chat box.
Yeah, I think I would, because okay, for me, why I could take the decision. Sorry, I'll turn off my video for now. I could take the decision because of the guidance that we have. Like I mentioned earlier, we have someone that, so there is also a part that is self-taught, but in general, we have a very passionate leader. So I would say, yes, I would say someone should come to this center, because the days you don't feel like it, you have someone that actually takes time to nod you in the right direction. So, and then the opportunities we have patient-wise, cases-wise, and you're able to, because everywhere the opportunities, but at least you can see things to the end to an extent. So, yeah.
Thank you very much. Dr. Simi, would you advise young residents, like young aspiring residents like myself, should you come down to ECH?
Yes, please. If you have if you have the opportunity, yes, please come to UCH. Despite the general challenge of this and that, I think we all faced all of those challenges in Nigeria. We have teachers, we have trainers that are really dedicated to this thing. HOD, he doesn't see impossibilities. For example, he pushes hard to make sure things work. It goes over and beyond to make sure things work in terms of training, in terms of making infrastructure available. So yes, so it sort of creates a bubble around us to an extent. Of course, when we move around, we see the reality of things, but we have a great leader. We have someone who knows what emergency medicine is, home and abroad. So if you have the opportunity, please come on board. And then it's a lovely set of people you'll be working with also, medical officers, residents.
All right, then for the final question for the day, the issue of remuneration. People have asked this question a lot. I think we had a before the session, we had a pre-session stuff questionnaire where we asked people to drop their questions beforehand, and people have been asking, what's the remuneration like? What's the remuneration like? Is UCH on IPPS? What's basically the scope of the remuneration for residents. So we'll start with you, Dr. Simi.
Yes, CCH is on IPPIS, so you get paid based on your grade level. So really, it's Nigeria. There's really nothing that is. I don't even think it's a Nigeria thing. There's really nothing that can be enough, so to say. But to a good extent, you're comfortable. And like my teachers used to say when I was in school, you have, although it's maybe it's not as rosy as that now, even self. They say you have enough money to take care of your family members, but you don't have enough money to chook your nose into family matters, like extended family matters. So yes, we are on IPPIS and UCH.
Okay, all right. So, Dr. Towenna, what's the experience like in Cedar Crest? Is it a
Okay, so
similar
it's the same thing, but I think Sacras is like, it's already private, so it really depends.
Sorry, I can't hear you. It's cracking. Hello? Hello, can you hear me? I want to know if the problem is from me.
What they can offer. We don't have
Okay.
what's it called? So when we got, like she said, it could be better.
Hello, Dr. Towenna, we can't properly hear you. Okay, I think she had network issues. We lost the connection there. But for those people interested in more details about those particular centers, please forward your questions to us. Directly, we'll find a way of getting those answers to you. Thank you so much thank you. At this juncture, I would like to appreciate Dr. Towenna and Dr. Simi for making it. Okay, sorry, Dr. Simi, just a quick one. Someone has a question. Is emergency medicine part of the program in West African College of Physicians now? Because it seems as if it's only at national. So, Dr. Simi, if you can answer that quickly.
It's still just as at national, but work is ongoing to make sure West Africa it's West Africa is involved too, but it's just at national level for now.
Okay, all right. So thank you very much for that. At this juncture, I would really like to appreciate our speakers, Dr. Simi and Dr. Towenna. I really learned a lot from this webinar. I believe our participants have also learned a lot, and also the other residents that came from University College Hospital Ibadan. Despite the hectic work schedule that you have earlier on told us about, you people still made out time to make it for this event. We are very, very grateful. Words cannot express our gratitude at this point in time. Thank you so much for making our time to be a part of this. I'm sorry I didn't properly get the names of the 3 residents that joined in, but my appreciation sincerely goes out to everyone for making it to this event. Thank you so much for coming. Thank you, Dr. Simi, and thank you to your baby too for allowing us to have the meeting. Thank you, Dr. Towenna, for making it here. So at this point in time, I would be inviting the president to quickly give his remark as we round this up. And we have announcements for our Emergency Medicine Interest Group of Nigeria, the members of our organization. Please stay tuned. So you would also want to watch out for the other fireside chats we'll be having with other people from outside the country, and you get to see different perspectives. Thank you so much, Dr. Simi. Thank you so much, Dr. Towenna. And to the participants too, thank you very much. Mr. President, the floor is yours.
All right. Thank you so much, Dr. Lamayaku, and good evening, everyone. My name is Dr. Lawan Abdulrazak Ali, and I'm the president of Emergency Medicine Interest Group Nigeria. Sorry, I couldn't have my video on at the moment. Kindly bear with me. And I would like to appreciate again our guest speakers for today, Dr. Towenna and Dr. Simioluwa for the wonderful discussions we have had. They were very impactful and very enlightening. Thank you so much. And we look forward to more fruitful discussions in the future. Thank you so much. And to our guest residents that popped in, Dr. Idaya Olubasayo, Dr. Adetola Ahobi, and Dr. Usman Adedeji, thank you so much for your insights and thank you so much for being with us today. Also, I would like to appreciate all our members and guests that joined this session. We appreciate your forbearance throughout the session and we hope you will join our subsequent sessions also in the future. And just to give you a quick input, there are actually 9 centers accredited for emergency medicine residency training now. There used to be 7 before, but there were 9 now. I think the latest addition include National Orthopedic Hospital Ibofi in Lagos, Abakar Tafawa Balewa University Teaching Hospital, and Obafemi Awolowo University Teaching Hospital Ile-Ife. I think originally we used to have UCH Ibadan, ABU Zaria, UNTH Enugu, UBTH Benin City, and Lagos State University Teaching Hospital and Syracuse Hospital Abuja. So there are 9 right now. And regarding West African Emergency Medicine Faculty, work is ongoing now. I believe there is movement to see the incorporation of the emergency medicine faculty in the West African College of Physicians. However, it's still ongoing. It's not yet finalized, but be on the lookout. It will be on board very soon. And to all people willing to, start their residencies in Nigeria, kindly note that most of the consultants are part of our advisory boards. So just try to keep showing up during our sessions. You may likely get to meet them and we may likely get to recognize you and you may likely get recommendations and, who knows, somebody might even offer you a residency slot if you impress him. You know how Nigeria is. So be on the lookout and try to join us. And just to give you an insight, next week, same time, we will be having a different session with the head of department of emergency medicine residency training in University College Hospital Ibadan. So just get ready. There are enticing sessions ahead, and we look forward to a more robust engagement this year in emergency medicine interest group. Thank you all for joining, and I wish you a joyous and very educative new year in emergency medicine interest group. Over to you, Dr. Lama.
Okay, thank you all very much. Thank you, Mr. President, for that remark. And at this point in time, please, I would like to say that to our emergency medicine interest group of Nigeria, our members, that this year, please, you would want to participate as much. Our case of the week that is running weekly on the newsletters, as you well know, that there will be recognitions for this case of the week winners at the end of the year. So put those amazing brains to work and participate. Please try and check our newsletters, check your mails. There are lots of opportunities that are written out there. Please try and check out your mails. Regularly check your mails for those updates. And then we'll have some announcements coming up very soon within the year. We have our emergency medicine merchandise that we are currently working on. So I'm saying this to let you all know to start budgeting. We would have our shirts and all of that coming up very soon. Other updates you would find out on the group chat and buy your meals. So thank you very much. Have a very beautiful evening. Thank you to our participants, and thank you to the AMIG Nigeria executives for putting this together. None of this would have possible without you before. Have a very lovely evening. Good night.